Good afternoon. It's a great pleasure and honor for me to be here today with our African colleagues. My name is Hussam Andil. I have not seen this elegant group of African colleagues in any meetings, at least in the past 10 years. Without any further ado, we will start this session with Professor Karim Saeed. He will talk about management of carotid artery disease in 2024. We have an elegant elite group of chairmen, and we will talk more about how important these kinds of meetings in our current day practice. And I will not forget to congratulate Egyptian Society of Cardiology and European Society of Cardiology for making this happen, especially my brother and colleague, Professor Magdi Abdelhamid. Fadl Karim.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, and thank you for this kind invitation. In this presentation, I'm going to discuss how to think about carotid disease as a cardiologist, not as a neurologist or a man who is going to do some structural intervention. Basically, I have 6 questions for carotid diseases. Should we screen any patients for carotid disease? And how to assess carotid disease? And how to manage patients with carotid disease after a stroke? And how to manage a patient with carotid disease who is asymptomatic? And if he is going to have some plaques, which is the best, stenting or endarterectomy? And what about the antithrombotic therapy in patients with carotid disease? The rationale behind screening for carotid disease is promising to prevent a stroke and to assess the cardiovascular risk. However, routine screening is not recommended because the prevalence of carotid disease is not high and it is not cost effective, and we don't have a good evidence to support doing this is associated with the reduction of the risk of stroke. So we should go for selective screening to detect those patients with highest risk for event. This includes patients with multiple risk factors, and in the last guidelines, they chose to screen patients with 2 or more risk factors, giving class 2P level of evidence C. However, we have many other group of patients at high risk. These include patients with severe coronary artery disease, those going to CABG, those with peripheral arterial disease, those with carotid bruit, and those on hemodialysis. So when we meet one of these group of patients, we should ask for carotid assessment. How to assess the carotid? In the last guidelines in 2017, we have the option between sonography, MRI, or CT. And the first choice was given to the sonography. However, in the last guidelines, it is stated clearly sonography is the first line imaging to diagnose disease in the carotid territory. And how to assess this stenosis? We go for assessment of the diameter stenosis. And we have 2 methodology based upon 2 landmark trials. The NACET, where we compare the residual stenosis to a reference, and the reference here is the internal carotid artery. Other trial, the ESC trial, compared the residual narrowing to the narrowing at the pulp of the carotid. However, now in the guidelines, it is a NACET that should be used and not any other criteria. This is new in these guidelines. So when you have a reporting a stenosis in the carotid, we should ask whether it is assessed by the NACET, which is okay, or the ACID, which should be repeated, because the ACID method overestimates the stenosis. If we have with an ACID stenosis with 60, it is 80 by the other method. Now, if a patient had a stroke or TIA, meaning symptomatic, how to manage these patients? First, what is the definition of symptomatic carotid artery disease? This is a patient who have a history of ipsilateral stroke or TIA only in the past 6 months. whether it is hemispheric affection or ocular amaurosis fugax. The problem here is the recurrence rate in the early phase is extremely high. In the first week, 20% of patients will have a recurrent event. And within the first 3 months, up to 30% will have a recurrent event. And this event is a major event. 50% will die or will have a major stroke and become bedridden. So we have to intervene. First, we should offer medical treatment. It is class 1 recommendations with good blood pressure control, lipid lowering down to 55 milligram per deciliter, among others. And here a message. For decades, it was thought that lowering blood pressure in patients with severe artery stenosis is not recommended. No, we can go by the guidelines, but to avoid aggressive lowering. The guidelines recommend doing carotid endarterectomy surgery in patients with diameter stenosis between 50 and 99, not total occlusions, with a team who has experience that provide less than 6% 30 days mortality or stroke. And this is based upon 3 major landmark trials that compared endarterectomy to medical treatment. And as we can see here, between 50 and 99, there is marked risk reduction in terms of stroke, any stroke, and low number needed to treat. However, if there is a total occlusion, there is no benefit. And it is recommended to do this endarterectomy within the first 14 days, because pooled studies show that the maximum benefit is taken within the first 2 weeks. The earlier the better, but not within the first 2 days. What about stenting in this type of patients? We have many trials. We have here 10 randomized controlled trials that compared endarterectomy to stenting. And within the 30 days after the procedure, there is increase of the risk of stroke, any type of stroke and death in patients undergoing stenting compared to patients undergoing surgery. Afterward, after these 30 days, both strategies have equivalent outcome. So the decision is based upon the outcome in the first 30 days, what we are expecting. If the surgery is at high risk, so we can go for stenting. Otherwise, stenting is a classic option in those patients. So in high-risk surgery patients, we will go for stenting. And when we define patients at a high surgical risk, this is anatomical or clinical, patients with active coronary artery disease or heart failure, patients with advanced kidney disease or liver disease, pulmonary disease can go for stenting, and patients with some obstacle to do satisfactory endarterectomy, such as high up lesions above C2 or behind the clavicle can go for stenting. And of course, some advocate to use stenting as an alternative to carotid endarterectomy, and this is given class 2P with level of evidence A, based upon 3 trials. However, this should be an age dependent. Only below the age of 70, we can go for stenting. Above the age of 70, coronary endarterectomy is the standard, and the benefit is not this high. On the other hand, how to treat patients with asymptomatic carotid stenosis? Again, definition of asymptomatic here, lack of symptoms any time, or the occurrence of stroke or TIA beyond 6 months earlier. And here we have to make a balance between the risk of stroke, which is not this high, and the risk of the procedure itself. Within the first 30 days, it can carry the risk of death or actual stroke. The guidelines, again, give class 1 recommendation for these patients. This is the only class 1 recommendations in patients with asymptomatic carotid artery disease. Then the vascular team, the neurologist, can meet and to make a balance between the risk of stroke versus the risk of the procedure itself. And here we can go for some well-defined high-risk criteria. If the patient is having a contralateral stroke on the other side, this is a high risk. If there is an ipsilateral silent infarction by MRI, this is a high risk. Sonography can give a clue. The percent diameter stenosis is not a risk factor. However, if there is a progressive stenosis, more than 20% per year, among other features, MRA can detect features of vulnerable plaque, such as the lipid pool or the blood hemorrhage within the plaque itself. When we find one or more of these criteria, we can predict this patient may have a stroke in the near future. Again, the guidelines give class 2A recommendation to do intervention for these patients, providing that the stenosis is more than 60, not 50 as in symptomatic, and the plaque is having one high-risk criteria at least, and the expected survival for these patients is more than 5 years, and with a competent vascular team with event rate less than 3% in the first 3 months, 30 days, I mean. And accordingly, it is class 2A with level of evidence B for average risk patients to have carotid end arterectomy again. This is based upon 3 landmark trial again, and as we can see here, 30 days death, risk of stroke or death is less than 3%, and this is the rationale behind the number of 3 for the results of the team. If the patient is a high risk for surgery, we can go for stenting, this is class 2B. And again, it can be alternative for stenting, for carotid artery enterectomy, if the patient and the team feel this is a good option for the patients. Finally, stenting or end arterectomy. A point here to remember is that all the data we were discussing were derived from trials done in the 80s and the 90s of the last century. And when they compare something to medical treatment here equal aspirin, only aspirin. We do not have adequate data how to compare, what is the outcome when to compare stenting or end arterectomy versus modern medical treatment with aggressive lipid lowering, with modern antithrombotic treatment. We do not have such data. And all data were derived for stenting from transfemoral approach, with increased risk for strokes when we are going to the aortic arch and the carotid origins. Now we have a new technique, which is transcarotid artery stenting, TCAR, in which there is a hybrid cooperation between the surgeon to make an incision at the root of the neck and introduce a sheath through which a stenting can be introduced directly under a protection of a neuroprotective device that shunts the blood away from the cerebral circulation. Till now, we do not have data that compared stenting versus optimal medical therapy. We are waiting the results of the CREST-2 trial that have 2 arms. One arm that compare optimal medical therapy versus stenting, the other arm optimal medical therapy versus end arterectomy in patients with asymptomatic carotid stenosis. Finally, antithrombotic therapy in patients with carotid disease. For those who have asymptomatic stenosis with plaque more than 50% lumen reduction, antiplatelet therapy, usually aspirin. For those patients who have a stroke or TIA, we will give DAPT for at least 3 weeks and up to 3 months, then SAPT. After end arterectomy, only aspirin. After stenting, DAPT for 1 month. And after this, we can go for SAPT, usually aspirin. So to conclude, here are a summary of the answer of the 6 questions. To screen only for high-risk selected individual. How to assess, it is sonography using the NACID method. How to treat asymptomatic patients, optimal medical therapy, and revascularization when the stenosis is more than 50 and the risk of the procedure is less than 6%, only within the first 2 weeks of the procedure. For asymptomatic patients, again, optimal medical therapy and revascularization when the stenosis is more than 60% and the procedural risk is less than 3% for high-risk plaque only. End arterectomy is still the preferred method based upon an old data. Stenting only for high-risk surgical risk patients, and it may be alternative for end arterectomy for high-risk patients with low recommendation and low level of evidence. Antithrombotic therapy, SAPT for all, unless the first month after stenting. and the first 3 weeks to 3 months after an event, no role for antithrombotic or anticoagulant agents. Thank you for your attention.
Thank you very much, Professor Karim. You did a wonderful job. I can see Professor Galal wants to address. Dr. Galal بيسألك, how do you know this is a high-risk plaque?
ممكن أرجع بالسلايدز. Okay, this is based mainly upon imaging of the plaque. If the plaque is having progressive narrowing, if the plaque is having features of much lipids,
high core, high lipid content,
yes.
20% increase. You did this very well. You said it clearly. If it increases by 20%.
Over years, yes.
Yeah.
Age is not a predictor.
Yeah.
The diameter stenosis is not a predictor for
I think
asymptomatic.
the most important slide that you showed today is that asymptomatic patients with carotid disease, no matter what, whether they have severe disease, whether they have total occlusion, whether they have intermediate disease or mild disease, all of them, medical treatment is class 1A for all of them.
Yes.
Yeah.
Thank you, Dr. Karim, for a wonderful presentation. Just 2 comments. First, you identified high-risk patients for carotid endarterectomy in the table, including those who need bypass surgery in the next 30 days.
Yes.
Open heart surgery.
Yes.
And this represents the majority of our patients. Therefore, do you recommend carotid endarterectomy despite having high risk or carotid artery stenting based on the available evidence?
In patients with MI.
No, they are candidates for open heart surgery.
Okay. Okay, this should be upon the type of the patient. If the patient is having acute coronary syndrome and the surgery should be done on urgent basis, so we can go for CABG. And we have some data that doing the carotid endarterectomy with CABG may be done with a good border of safety. If the patient is elective and safe, we can postpone the CABG procedure. Then we can do the stenting here, not the carotid endarterectomy. And after 1 month, we can go for the CABG surgery.
Any other questions?
Is any of our guests from Africa having a program for carotid stenting, active program, or doing himself active carotid intervention? Do you have, the question is, do you have a program for carotid stenting in your institution, or do you participate yourself in carotid stenting? I can see that no one in this room from our African colleagues is doing this. And this tells us very important, I have been in the business of coronary intervention, and I'm sure all of my colleagues have been the same. And we have seen an era of a great interest in carotid intervention, but this has regressed remarkably after having clear data of the limited benefit of carotid intervention in the inappropriate patients. You have to have the appropriate patients to see any benefit. Not only it is very expensive, but it adds a lot of risk and it needs a lot of expertise.
Professor Hassam, I have nearby me Professor Fatoumata from Ivory Coast, and she is telling me that they have a program only in the private centers, but university and public centers, they don't have that.
Yeah.
Vous n'avez pas des cas en privé, mais à l'université, pour oui, dans les privés. Très bien.
Yeah, so we might have in Africa very limited private centers that is doing this, but the message is that carotid intervention is only for a very peculiar group of patients who are having high-risk plaque in the 14 days, as Professor Karim said, after the acute event, and in highly symptomatic patients. Do we need any other questions? I think we have to move to the next speaker. شكرا يا كريم.
Now we shift to the second presentations about the guidelines of peripheral arterial disease and aortic disease. Professor Mina Sami from Cairo University.
Today, I'm going to talk about 10 messages from the guidelines of the peripheral and the aortic disease. The difficulty in this is that before these guidelines, it was two guidelines, the aortic in 2014 and the peripheral in 2017. So they combined them in one guidelines. So they included all the vascular beds, included the carotid, like Dr. Karim talked about, the peripheral for the upper limb and the lower limbs, and the aortic and the renal. So the first message from the guidelines is that a multidisciplinary team is needed, starting from the cardiologist to the cardiac surgeon, to the vascular surgeon, to the all the other specialties. Also, peripheral arterial disease are much high prevalent, and unlike the coronary artery disease, they are underdiagnosed and undertreated. So we have to have some screening to catch them in an early phase because they are often asymptomatic. So the first message is regarding the diagnosis. The guidelines recommended a non-invasive tool, which is the ankle brachial index, as the initial diagnostic test, class 1 level of evidence B. Also, it's a surrogate for cardiovascular events. And for imaging, it shows the duplex as the recommended first-line imaging technique, class 1 level of evidence B. Regarding the classification of patients with peripheral arterial disease, they classify the patient to either they are asymptomatic peripheral arterial disease, or symptomatic effort-related, or critical or chronic limb ischemia, the last part of the classification. The third message was the treatment, and they stressed on the importance of the medical treatment. We should not run to the interventional treatment before the medical treatment. It's the same slide Professor Dr. Karim has shown for the drugs. So we start with the pharmacological treatment, then we go for the supervised exercise training and the lifestyle. Regarding the revascularization, what's new in the guidelines was revascularization for asymptomatic peripheral arterial disease patients is no longer recommended, it's class 3. And it is recommended in symptomatic peripheral arterial disease patients only after optimal medical treatment and exercise. So this ensures the importance of medical treatment and exercise like in chronic coronary syndromes. The fourth message is the new recommendation for the antithrombotic treatment. Before these guidelines, we know that we should use a single antiplatelet, whether it's aspirin or clopidogrel alone, class 1 level of evidence A. What's new is that we can use combination. And I guess there is a whole presentation about the antithrombotics of rivaroxaban with aspirin for patients with peripheral arterial disease who have a high ischemic risk and a non-high bleeding risk. Again, a combination of the same drugs, rivaroxaban with aspirin, for patients with peripheral arterial disease after revascularization. This is new in these guidelines. The fifth message in these guidelines was regarding the other new recommendations. The last peripheral arterial disease guidelines was in 2017 before the latest dyslipidemia guidelines. So the cutoffs were different, but all of us know that peripheral arterial disease is a very high risk atherosclerotic cardiovascular disease event. So we should deal with it like the coronary and the other atherosclerotic cardiovascular disease. So the goal is less than 55, and we should use all the weapons available to go to this target, including the statins, the PCSK9 inhibitors, and also the newly added pempedoic acid. Regarding the exercise, it's class 1, level of evidence A, to have a supervised exercise training. Also recommended as an adjuvant therapy for those who are undergoing endovascular repair. When the supervised exercise training is not available or not feasible, we can go for help the patients with calls or logbooks or connected devices. Walking should also be considered as the first line of training. If walking is not possible for the patients, we can go for other modalities like strength training, arm cracking, and cycling. What they recommended is to exercise 3 times per week, each 30 minutes for 12 weeks under supervision. Finally, the follow-up, they recommended class 1 level of evidence C to follow up each year. Regarding the 5 messages in the aortic disease, the first message was that we need to use a standard nomenclature and measurements. This is the segments of the aorta, starting from the root to the arch to the descending into 11 segments. Also, we should use the same measurement in using the CT or the CMR. If we are using echo, we measure the aorta leading edge to leading edge. If we are using CT or CMR, we go inner to inner. The second message is the risk factor for thoracic and abdominal aortic aneurysm. We all depend on the diameter of the aorta as the main parameter for the aortic root replacement or aorta replacement or surgical intervention. And it's a very important parameter, but it's not a perfect parameter. For this reason, the guidelines included some other features or risk factors for the aortic valve disease. Starting with the patient's height and also the aortic length. If it's more than 11, this is a threshold for surgery. The rate of the yearly growth and the phenotype. Of course, the root is more risky than the ascending phenotype, so which puts the root at a higher threshold for aortic valve intervention, aortic root intervention. Regarding the new recommendations, it's surgery recommended if a maximum diameter is more than 55. In the older guidelines, it was class 2A, now it's class 1. And whenever possible, we use valve-sparing aortic root replacement. Also regarding the new recommendations, so the cutoff is 55. We can go to more than 52 if the surgery is low risk for this patient. And actually, we can go from 45 to 50 if the patient is going for another aortic valve surgery. What's new in the recommendation is this box down here. If the cutoff is 55 or 52, but we can use a cutoff of 50 if we have those risk factors I mentioned in the previous slides, like the growth of the aorta, the presence of resistant hypertension, the short stature of the patient, the root phenotype, the aortic length more than 11, age less than 50, and desire for pregnancy and aortic coarctation. After this, the guidelines used the data to formulate this algorithm, and they divided the patient into like this. And according to the cutoffs, we can use this algorithm to decide which patient will undergo aortic intervention. After this, the guidelines dealt with the heritable thoracic aortic valve disease, and they took the age of 60 as a cutoff. If the patient is younger than 60 years and he has aortic dissection or aortic dilatation with no hypertension and no risk factor for cardiovascular disease, this is an indication to send him to a specialized center. If he's older than 60, we check the aortic root. If it's more than 3, the Z score, and still he has no risk factors for hypertension and no risk factors for other cardiovascular disease, we can refer him for a specialized center. In this specialized center, they do 2 things. First, the aortic imaging, and second, they do the genetic testing for these patients. The 9th message was dealing with the aortic dissection regarding the diagnostic algorithm and the classification. They use the aortic dissection detection risk score, which takes one of the high-risk conditions, the high-risk pain features, and the high-risk examination features. And then they calculate the score depending on this. If the score is more than 2, they act as its aortic dissection and they proceed with the management. Like doing the CT from the neck to the pelvis, in addition to the transthoracic echo and the ECG. If the score is less than 2, they start to exclude the other possibilities. Like we do an ECG to exclude STEMI. If it's STEMI, we go to the ST elevation myocardial infarction guidelines. We do a chest X-ray and POCUS if available. And finally, we can go with CT to exclude aortic dissection or aortic acute aortic syndromes. If the diagnosis was confirmed with acute aortic syndrome, the guidelines recommend that we use this classification, the TEM classification. So it helps us with the management. The T is the type, whether it's type A, type B, or non-A, non-B. The E is the entry point, at which part of the aorta, and the M is the malperfusion. If there is malperfusion, and if it's there, coronary, supraaortic, or down to the spinal and visceral. The last message from the aortic guidelines was the treatment. Regarding the medical treatment, of course, it's important to rate and pressure control using intravenous labetalol or esmolol. If contraindication to beta blocker, we can use non-dihydropyridine calcium channel blockers like diltiazem or verapamil to try to reach a heart rate of 60. If the blood pressure is controlled with the beta blocker, then it's okay. If not, we can go for the intravenous vasodilators like nitroprusside or ACE, targeting a blood pressure of less than 120. And finally, a pain control using intravenous opiates. Finally, the interventional treatments, it depends whether it's type A acute aortic dissection, of course it's class 1, the surgery, or type B acute aortic dissection, which it's not always we go for surgery. If there is a complication like contained rupture or organ malperfusion or extension, or the refractory pain more than 12 hours, then it's complicated type B, we need to do something. If it's favorable for TEVAR, then endovascular repair. If it's not, we go for open surgical repair. If the type B is not complicated, we try to go for this one of the high risk features of the CT or MR, like the aortic diameter more than 40, the entry tear more than 10, the total aortic diameter more than 5. If we have any of these of the following, again, we ask ourselves if the patient is suitable for TEVAR, then TEVAR. But if he's not suitable for TEVAR, he will not go for surgery. The treatment will be optimal medical treatment and surveillance. Thank you.
Thank you, Yamina, very much. You have done a very good job in reviewing and highlighting the important points in the guidelines. I want us and the attendee to remember one figure in aortic disease in which you will be ready to ask for either surgery or intervention in patients. Aortic disease is mainly disease of the elderly. We do see some patients below the age of 50, but most patients are above the age of 60, and hypertension is the most important risk factor. It used to be 5.5 centimeters. I have seen today, you have showed it to be 5.2, yes, unless you have other important criteria. What is the figure? Number.
Figure?
The number in which you should intervene. Or
regarding the aortic dilatation, the cutoff, it's still 5.5.
Okay.
Okay, but if it's 5.2, we can go if the risk of surgery is low for the patient. We calculate the risk of surgery for the patient. If it's low, we can go.
So it's still 5.5?
Yes.
Okay.
Thank you, Dr. Mina, for this comprehensive revision of guidelines. It needs more than one lecture. Regarding what Professor Hussam said, now the indications for intervention for aortic root dilatation not only dependent on the diameter, but dependent on the length, a degree of increase more than 3 millimeter per year. Also the length, more than 11 centimeter, and the configuration, the phenotypes of the aortic root dilatation, whether root dilatation, extended, or ascending aorta. This is very important. The second comment regarding the indications for intervention for claudicant patient or asymptomatic patients. Because we can see some malpractice in some juniors, they do ad hoc intervention for a lesion in the lower limbs. This is contraindicated. No routine intervention in patients asymptomatic lower limb peripheral arterial disease, and even in chronic threatening limb ischemia, you do not do anything for those patients unless you have a vascular team approach or a multidisciplinary approach.
Yes.
Thank you.
Thank you.
Ready to move to the next?
Thank you, Mina. Our next speaker, Professor Mohammed Salim, will talk about acute aortic syndrome, current status of diagnosis and management.
Thank you, Professor Magdi Abdelhamid, for this elegant meeting and for the kind invitation. I'm so delighted to be part of this important and elegant meeting. And also thanks my colleague, Dr. Mina, because there is some overlap in the last 3 messages regarding the acute aortic syndromes. However, I will go in more details. Yes, thank you. Okay. Of course, the acute aortic syndromes is a spectrum of diseases, not only one disease, but the commonest presentation of acute aortic syndrome in more than 80% of cases is the acute aortic dissection. And in addition to intramural hematoma, penetrating aortic ulcer, aortic pseudoaneurysm, and traumatic aortic injury. Also, we don't have to forget that sometimes we have the acute aortic syndrome, which is iatrogenic, following intervention or surgical intervention in the aorta. Regarding the classification of acute aortic syndrome, we have to say that still the Stanford classification is used to describe whether it is type A, involving the ascending aorta, or type B, involving mainly the descending aorta with sometimes retrograde extension and confined to the arch. But here, the new classification recommended by the European Society of Vascular Surgery and European Society of Thoracic Surgery, in which it's called TEM classification, depending on the type of dissection, whether it is A, B, and non-A, non-B. Non-A, non-B, it is the old DeBakey type 3A, in which the dissection is in the descending aorta with retrograde extension and confined to the arch. And the second letter E for the entry or the site of intimal tear, in which part of the aorta, and the new introduction of what's called malperfusion, which by itself is a strong indication for intervention, whether it is coronary, supraaortic, spinal, visceral, with or without symptoms. Early diagnosis for acute aortic syndrome is a major pitfall in managing those patients. Therefore, diagnostic multi-parametric algorithm is proposed. And this algorithm combines what's called the aortic dissection detection score, in addition to some lab tests like D-dimer, in addition to echocardiography. So it's class 1 recommendation in patients presenting with clinical features compatible with possible acute aortic syndrome, multi-parametric algorithm for ruling in or ruling out this syndrome using this detection risk score assessment is highly recommended. I will go rapidly through this algorithm depending on these features. We have 3 types of features. We have high risk condition like risk factors or comorbidities like presence of Marfan syndrome, family history of aortic disease, known case of aortic valve disease, recent aortic manipulation or intervention, or known aortic aneurysm. Each feature of this will be given 1 point. And the second is high-risk pain feature. The pain is typical of acute aortic syndrome, like central chest and referring to the back, coming from the peak, from the start. It may be ripping, tearing, excruciating, and so on. And the third feature is the high-risk examination features like hemodynamic instability associated with the sudden development of pain, perfusion deficit like pulse deficit, differential systolic blood pressure between two arms, focal neurological deficit, or new murmur suggestive of acute aortic regurg. If these points will be given 2 or more, so it is recommended to do ECG-gated CT from the neck to pelvis without any delay, in addition to focused transthoracic echo rapid examination. If the score risk for this detection is less than 2 points, so I will go for ECG to rule out STEMI, and then go for chest X-ray, point of care ultrasound examination or rapid echo, D-dimer, chest X-ray, and if any one of these investigational tools will point to the acute aortic syndrome, I will manage like the presence of aortic dissection or acute aortic syndrome. If not, I have to consider alternative diagnosis. These are the new recommendations in acute aortic syndrome, the recommendation of the ECG-gated CT from neck to pelvis, as I have just mentioned, the focused transthoracic echo, and also the recommendation in those patients with suspected acute aortic syndrome for transesophageal echo for 3 reasons. One is to guide perioperative management. The second is to detect complications, or here in patients unstable and cannot go for CT, it is recommended to do transesophageal echo. Regarding medical management, you cannot do good medical management and go for the targets of heart rate and the blood pressure in acute aortic syndrome without good control of pain. So pain control is coming top priority in those patients using intravenous opiate, and you have to titrate the dose to achieve proper and good pain control. Then, as my colleague mentioned, titrate to heart rate less than 60 beats per minute, and the new recommendation of deltiazem or verapamil when beta blocker like labetalol or esmolol are contraindicated, and then continue to pressure control using intravenous vasodilator like sodium nitroprusside or AC inhibitor IV like enalaprelate to titrate blood pressure systolic less than 120, and goal is the lowest possible blood pressure without affection of adequate perfusion to important organs. And this is new recommendation of adding non-dihydropyridine calcium channel blocker in case if beta blockers are contraindicated. Then the most important question, when to intervene for these patients, and this will depend on 3 factors. Immediate intervention depends on, number 1, whether this contained or free aortic rupture in acute aortic dissection, the type and localization in the aorta, and the organ malperfusion. First, if we have type A aortic dissection, of course, this will go directly for surgery, open heart surgery or open cardiac surgery. And the main technique is the aortic root replacement is recommended as a class 1 with a mechanical or biological valve conduit. In the new guidelines that in patients presenting with acute type A aortic dissection is to transfer from a low to high volume aortic center with the presence of multidisciplinary team should be considered to improve the results, survival, provided that the transfer can be accomplished without significant delay in surgery. And also in selected patients, valve sparing route for the first time is recommended or may be considered when performed by experienced surgeons, because not every cardiothoracic surgeon is efficient in such type of techniques. In addition to some new strategies in aortic repair, like aortic valve resuspension, open distal anastomosis, and hemi-arch repair in some types of dissections. Here are some also of the new recommendations regarding the malperfusion in patients with acute type A aortic dissection. Generally, malperfusion is a strong recommendation for intervention. And this is new recommendation when the patient presenting with type A aortic dissection with clinically significant mesenteric malperfusion syndrome, immediate invasive angiographic diagnostic to evaluate percutaneous malperfusion repair before or directly after the aortic surgery. But this could be done only in centers with high experience and high volume in dealing with such cases, not in every center, of course. Then we will go for if the dissection is type B, distal dissection. We have to make a clear distinction if this type B dissection is complicated or non-complicated. For type B dissection, it will be complicated if it has one of the following criteria: contained or free aortic rupture, organ malperfusion, as I have just mentioned, extension of the dissection, progressive aortic enlargement on serial imaging, refractory hypertension despite use of 3 antihypertensive medications, refractory pain after 12 hours with adequate doses of opiates. If this is complicated type B or uncomplicated. For complicated type B, we have to consider thoracic endovascular aortic repair or TEVAR, provided we have the favorable anatomy. Favorable anatomy here depends on 3 factors: adequate distal landing zone, adequate proximal landing zone, and also adequate and secured access. If you have such anatomical features, you have to go for TEVAR. And also provided that the life expectancy of the patient is more than 5 years. Also, one of the following high-risk features, like the diameter of the false lumen, aortic diameter, entry tear, or high-risk clinical features will favor the TEVAR versus only conservative management with optimal medical treatment and wait-and-see approach. Now we will go for the recommendations for the management of intramural hematoma, and the recommendations for this in line with the same recommendation of the acute type A aortic dissection. If it is type A, urgent surgery is recommended. Type B, initial medical therapy under careful surveillance. If uncomplicated, repetitive imaging. If it is increasing, you will go for surgery. And in complicated type B intramural hematoma, TEVAR is recommended. And here is the high-risk features of the intramural hematoma, both in type A and B, regarding difficult blood pressure control, ascending aortic involvement, or type A, the diameter, progression to aortic dissection, and many other anatomical features, making it as a high risk. The same for penetrating atherosclerotic aortic ulcer, the same recommendation, whether it is type A proximal, type B descending, complicated, non-complicated, it is the same. But on top of that, the last one, in isolated asymptomatic small penetrating atherosclerotic ulcer with no high-risk features, conservative management with regular surveillance and medical treatment may be considered. Also, for traumatic aortic injury, we have to classify the grade 1 intimal tear, intramural hematoma, pseudoaneurysm rupture. For grade 3 and 4, it is recommended for surgical repair, and in cases of minimal aortic injury, like grade 1 or 2, initial medical therapy under careful clinical and imaging surveillance should be considered. This is the last part of my talk about the algorithm for follow-up after acute aortic syndrome. You will find detailed time follow-up and surveillance, and of course, the frequency of doing this surveillance will be more frequent when you are adopting conservative strategy or medical treatment, or the approach wait and see, because you have not to miss any high-risk features like progressive aortic root enlargement or progression of the intramural hematoma. Lastly, I want to highlight the most important items or the most important new changes in these guidelines. Acute aortic syndrome management involves medical treatment in critical care units and selective surgical intervention based on location and complications with the new classification depending on also on the presence of malperfusion or not. The main problem in these conditions continues to be delay in diagnosis of patients or transferring them to an aortic center. Improved diagnostic algorithm and reduced surgical complications have lowered the mortality rates of acute aortic dissection. And lastly, surgical, in addition to endovascular treatment in the subacute phase, is advised for high-risk patients with type B aortic syndrome. And thank you for your attention.
Thank you, Professor Salim, for a wonderful overview of such a hot topic. The main problem is delayed or misdiagnosis of such case. Can you convey a short message how to expect and diagnose such aortic syndromes?
Like this multi-parametric algorithm stated, you have to analyze accurately the type of chest pain of the patient and also the risk of this patient to develop acute aortic dissection and the comorbidities and also the clinical examination. If you have 2 or more high-risk features for this, you have to go directly for CT. CT is the most comprehensive and the most accurate method for detection of acute aortic syndrome. And if you are in doubt and you are made an ECG and you don't have a STEMI and still in doubt, also you have to refer a patient for CT.
And the sensitivity of CT for detecting a penetrating ulcer or hematoma is such high?
It is not like the type A aortic or type B aortic dissection, but it is more than 90% in most of the cases, especially if it is complemented or in addition to transesophageal echo in some patients.
Thank you, Professor Salim.
Professor Salim, thank you very much for your presentation. Any insights in the European Society guidelines concerning the control of blood pressure in both acute coronary, acute aortic dissection and stroke?
And stroke? I think in acute aortic dissection, the main here recommendation is the pain control and the systolic blood pressure less than 120. If it is associated with cerebral malperfusion, I think it should be considered in that I have not to go very low to maintain the cerebral perfusion. But it is not stated in the guidelines specifically if it is accompanied by stroke or not.
Thank you. Thank you very much. If no more questions, it gives me a great pleasure to introduce the next presenter, Professor Bassem Zarif, National Heart Institute. Professor Bassem Zarif is one of the researchers in Egypt, especially in the consensus. He's the guru of consensus of many disciplines, and he is the co-founder of psychocardiology group of Egypt. He will be talking about the antithrombotic therapy in patients with peripheral arterial disease. Please.
Good afternoon, everybody. It's my pleasure to be here, and thanks for the invitation. I congratulate the Egyptian Society of Cardiology, Professor Nabil Farag, and the dynamo of this meeting, Professor Magdi Abdhamid. Most welcome to the distinguished panelists from the European Society of Cardiology and our colleagues and professors from the Africa. My topic today becomes so easy after having the previous talks, so going to the recommendations of antithrombotic treatment for peripheral vascular disease, we should have an important message before we go in depth that managing peripheral arterial and aortic disease, it is recommended to adopt comprehensive approach that address the entirety of arterial circulation. This is essentially important because arterial disease most commonly come not in isolated form, and for coronary artery disease, we already have a combination of 90% of carotid, 16% of peripheral arterial disease, and 15% of renal arterial disease. And for example, in carotid stenosis, we have up to 60% that have already coronary artery disease, and for peripheral arterial disease, we have up to 70% that already have a combination of coronary artery disease. So we have to think global regarding arterial affection before we manage and tailor optimal medical therapy specifying antithrombotic treatment. And this is how to grade, because peripheral vascular disease, we can evaluate arterial system using the ultrasound-guided machines. So we have very important classifications about grade 1 to 5 with intimal thickening less than 2, 2 to 3, 3 to 4, more than 4, and complex lesion with grade 2, 3, 4, plus atheromatous, mobile, all ulcerated component. This is important to say because this is very important for the decisions of antithrombotic treatment, because complexity of the lesions can control our decision for antithrombotic and optimal treatment. And this is the optimal treatment. Here is the antithrombotics comes here, but we have to think global of optimal management of our patients, going to revascularization as a part and adequate medical treatment, starting with controlling cardiovascular risk factors from smoking cessation, healthy diet, weight control, and supervised exercise, and for medications for hypertension, cholesterol, and optimal glucose control, and finally, to tailor the antithrombotic treatment. And this is already had been provided before, that it's integrated regulations between different and many specialties, cardiologist, vascular surgeon, diabetologist, nephrologist, and they should integrate it from screening up to the final destination of management and optimal medical therapy. And for the decisions of antithrombotic, you will see this in the whole choosing of antithrombotic for different regions. We have to classify our patient to asymptomatic disease, symptomatic, and chronic limb with threatening ischemia. For asymptomatic disease, the decision is completely different between symptomatic and even between symptoms mild, moderate, severe, from non-disabling intermittent claudication to disabling intermittent claudication, and finally, chronic limb threatening ischemia with ischemia at rest or ulcerated or complicated. This may alter the decision in choosing the antithrombotic regimen for our patients. And finally, to have an overview of antithrombotic therapy, treatment with combination rivaroxaban, Riva, vascular dose, 2.5 twice daily, and aspirin should be considered in patients with peripheral arterial disease with high risk of ischemic risk from symptoms and from the morphology of ultrasound, and non-high bleeding risk. This is the same Riva vascular dose plus aspirin in those who developed following lower limb revascularization. And finally, all of this is class 2A indication, and aspirin for primary prevention may be considered in asymptomatic patients who are diabetic, high risk patients and not high risk lesions. Another important part is the in asymptomatic or asymptomatic, just you have to have an optimal medical therapy for at least 3 months before you think of revascularization. And finally, regarding intervention with chronic limb-threatening ischemia, although revascularization is the destination therapy, but we have to, regarding the overall risk factor control, cessation of smoking, healthy diet, aerobic activities, and behavioral counseling, and caregivers education and empowering, all of these with thinking about secondhand smoking and air pollution. This should be integrated into the management, and this is another, just highlighting the antihypertensive treatment, the same threshold, the same target, with focusing about ACE and ARBs medications of our patient. This is an integral part of optimal medical therapy, and this is for lipid lower therapy, the same goals with 55 or more than 50%, with the same armamentarium of treatment adding high-dose statin, adding then ezetimibe and PCSK9. This is about dyslipidemia and hypertension. What about diabetes? Diabetes, the control to 7 hemoglobin A1C, highlighting the importance of SGLT2 for our patients' vascular, GLP-1 recommendations for and avoiding hypoglycemia is essentially important. What about antithrombotic positioning in the treatment of our patient? Use of antiplatelet therapy with aspirin alone or clopidogrel alone is recommended for reduction of MACE with patient with symptomatic peripheral arterial disease. Treatment of a combination rivaroxaban vascular dose plus aspirin should be considered in a patient with peripheral arterial disease and high risk with non-high bleeding risk. Treatment of a combination rivaroxaban, the same plus aspirin, following lower limb revascularization. Use of antiplatelet and clopidogrel may be considered over aspirin, and this is the same like coronary for long-term treatment. Aspirin for primary prevention, you should be highlighted for high-risk patient groups, especially diabetics, and DAPT for at least 1 month after revascularization may be considered to reduce limb events, but only that's class 1 is the use of antiplatelet, aspirin, or clopidogrel for our patients. And this is the not to-do list, class 3 indication of antithrombotic therapy. Long-term DAPT in patients with peripheral arterial disease, not totally recommended. Oral anticoagulation monotherapy, unless another indicated by another indication, class 3 indication. Routine use of ticagrelor is out of order for our patients with peripheral arterial disease, and also it is not recommended to systematically treat our patients who are asymptomatic with any other signs of atherosclerotic cardiovascular disease with any of the antiplatelet. What about acute limb ischemia? Acute limb ischemia is urgent vascularization, but what about anticoagulation? Upon confirmation of acute lower limb ischemia, treatment with heparin may be considered, and in patients with acute lower limb ischemia following revascularization, if not on anticoagulation for another reason, DAPT or Riva aspirin should be considered. What about the carotid? We already heard about that. DAPT for the acute event if there is minor stroke, and for long-term single antiplatelet therapy. What about after revascularization for the carotid stenosis? 21 days DAPT therapy if there is a minor stroke, 90 days, not for all patients, for high risk, and finally long-term treatment with SAPT is considered following internal carotid revascularization. What about secondary prevention in aorta? In aorta, SAPT or clopidogrel low-dose aspirin should be considered for severe complex plaque. Anticoagulation or DAPT not recommended, it's a class 3. And finally, in patients with embolic events for aortic atheromas and evidence of aortic arch atheromas, SAPT is recommended to prevent recurrence. Finally, we have 2 important slides about long-term of antithrombotic therapy in patients with symptomatic peripheral arterial disease. After assessment of the risk level, we have 3 groups. First group, no risk of limb at presentation or high risk comorbidities. It is adopted for single SAPT, mostly aspirin or clopidogrel. We have some data in favor of clopidogrel, but this is class 1. And for patients requiring long-term anticoagulation for another reason, mainly AF, it will be single DOAC or anticoagulation monotherapy, and this is class 2B. What about high-risk limb presentation or high-risk comorbidities without high bleeding risk? Then aspirin plus rivaroxaban vascular dose will be class 2A indication. Finally, about chronic symptomatic peripheral arterial disease after endovascular revascularization, long-term anticoagulation is required. So we have 2 options: high bleeding risk, no high bleeding risk. If anticoagulation is recommended for the AF, for example, with high bleeding risk, so monotherapy with oral anticoagulation will be class 2A indication. If there is no high bleeding risk, so we can combine SAPT for 1 or 2 months plus oral anticoagulation, this is class 2A, and finally the final destination will be solo oral anticoagulation later on. If there is no indication for anticoagulation, so we will consider the bleeding risk. If there is no high bleeding risk, so the combination of aspirin and vascular dose of rivaroxaban plus minus clopidogrel. This is very, very important. This is the first time to hear about triple therapy for 1 month. This is class 2A, and finally the final destination will be a combination of aspirin plus rivaroxaban vascular dose. This is class 2A, and if there is a high bleeding risk for those, we have endovascular revascularization, we have DAPT for 1 or 3 months, class 2A, and finally SAPT, aspirin or clopidogrel. This will be finally class 1 indication. Thank you very much for your attention.
Thank you. Thank you very much, Professor Bassem. Do you think that there is a place for scores like CHA2DS2 score, CHA2DS2 score, or that score in peripheral arterial disease?
Like the European Society before, we have the data, then they will culminate it after trials to be culminated into a scoring system. We already annotated at the beginning of my talk that there is also the symptomatology will be kept into consideration in taking decisions of antithrombotic, the complexity of the lesions and the complexity of the patient, whether the patient very high risk profile, intermediate risk profile, or low risk profile. Yet, till now, we don't have a scoring system for decision of anticoagulation, but we have scenarios, as already mentioned in my talk.
Thank you.
Thank you, Professor Bassem. It seems that the intensity of antithrombotics in the field of peripheral intervention and management differs from that of coronary intervention, much less intense than in the coronary field. Second comment is, if you have a patient with asymptomatic peripheral arterial disease, we have a clear recommendation against antiplatelets. Despite having up to 70% of such patients may have associated coronary disease. How to explain?
Yeah, this is very, very important. And apparently in the start, I took some slides to explain how much is the combination between peripheral and the cardiac coronary patients, how the scoring of the profile of the patient. Also, even with diabetes, not coronary artery disease, we can have aspirin for peripheral arterial disease, just SAPT, only aspirin, just for prevention, and this is not for the prevention of the male, that's major limb ischemia. This is for the atherosclerotic cardiovascular protection, mainly to protect the heart from MIs and strokes or cardiovascular events in particular.
Bassem, thank you very much for an excellent lecture. Many of the patients that you have discussed have problems with smoking. And in our country, and I'm sure in many African countries, smoking is very prevalent. What will you do in a patient with aortic aneurysm, for example, that is coming to you and refusing to stop smoking and telling you, I cannot quit? What will you do? Will you do the intervention? Will you just do medical treatment? What is the same for carotid and other major problems? What will you do?
This is a very, very important question, and I already passed through the recommendation of lifestyle quickly. And smoking in particular had been highlighted, and number one, and the end, they highlighted second, smoking and pollution. And even going through, I think it's a major obstacle to achieve adequate control of patients with having smoking, especially with the peripheral arterial disease. And I think quitting the smoking cessation program should act to help those patients to get out of smoking, as they increased markedly the risk.
Okay, thank you very much. Now, this is the end of this session, and we'll now move to the final session of this excellent program.